Good afternoon or good morning, everyone. Welcome to this Drummond session from obstacles to opportunities. We're going to take a look at the FHIR app ecosystem. This is John Valutkevich from the Drummond Group, and I'm pleased to have John Travis, industry expert, with us here today in time. And John, since we have a Drummond session, most of the folks may be well aware of Drummond and what my role here is, but we're pleased to have a colleague on with us, John. Perhaps a brief introduction for the rest of those attending.
Sure, John. I am John Travis. I have my own LLC, but for a long time I was with Cerner and I led our regulatory strategy function. And very interesting to this group, we oversaw all of Cerner's certification efforts with the ONC, and Drummond was our certifying body as well as our testing lab. And I was involved with that for a decade and a half, dating way back to the very first certifications that occurred under Stark and I kickback for the EHR safe harbor that even predated our high tech. So long experience with working with HIT at the intersect of regulatory requirements of EHR products, and a lot of experience working with the Drummond Group. So happy to be here.
Great. Yeah, thank you very much. And for the benefit of the audience, a couple things what we'll cover today in our 30-minute session, while allowing for a bit of Q&A, we believe at the end is, John and I are going to go back and forth a little bit and start with talking a little bit about the legislative and requirement activities affecting the FHIR app ecosystem, of which most folks will probably be aware, and then talk a little bit about the challenges with the API and FHIR app ecosystem and some of the roles that'll play. And many of you are in the throes of that now. And then, as is always prudent, I think just to touch a little bit on where we see the industry and market going. So, again, I'll start at the outset, obviously, from a Drummond perspective, being one of the ONC ACBs, obviously, is we look at the Cures Act, right? And the recent activity over the course of the last 2 years or so to be able to bring the API infrastructure up at least to a level set. And we look at the EHR community opening up their APIs, level setting on a version of FHIR, incorporating smart on FHIR authentication capabilities, and obviously information blocking capabilities around that also to ensure that the data is made available within a certain environment. And we look at the EHR industry, and when you think about it, bulk data I'll reference G10 and obviously the prior G7 through 9 criteria as well to basically guide the EHR industry in terms of what needs to be made available and how to obviously secure it. So there's a level set there. And as many of you may be well aware, as we look forward to and parallel to that, the payer industry leverages that same G10 requirement in making patient data available via their APIs as well. So we've seen this activity, and we've seen that all boats will hopefully start to rise as the API infrastructure is settled on a standard and secure. And now it's just a matter of load to let folks know that there's opportunities around there to increase patient chain by API. So we have that coverage. What I'd like to do, John, as you're in the throes of this, obviously, is can you speak a little bit about some of the insights that you have as it relates to the proposed rule entitled
Yeah,
HTI?
John. I think there are several things that I would highlight that definitely underscore the strong support to the fire standard that ONC has given it. First, we see a proposal for a fire-based standard to apply to electronic case reporting. So the F5 criteria that up to now has not had a standard, just had basically a data set requirement. But we see as part of their proposal that a EHR vendor seeking certification could choose to use the FHIR standard to certify to for electronic case reporting. We also very significantly see a raising of the floor with the U.S. data set for interoperability. That is proposed as version 3 that will be supported. ONC anticipates with adopting the U.S. core version 6, which would support all of the semantic standards, vocabulary standards to go with the U.S. CDI. And so that is being consumed importantly for the use of FHIR and certification criteria as a raising of the floor of what is the required data set to be made available through the FHIR standards, especially under G10, as John mentioned. And then I think lastly, there is a significant criteria being proposed for patient requested restrictions of consent relative to the disclosure of EHI. And part of that is using the FHIR standard. So for the ability for a patient to request specific data elements or data classes present in US CDI version 3 to be withheld from disclosure. And that's a very significant requirement, and I think is going to pose a lot of work ahead for certified EHR vendors and HIT vendors who seek certification to that criteria, which is going to be required of them. John, I
Yeah,
think you're going to turn back to you a little bit. I think also the insights condition has got a very important stripe of dealing with API use.
yeah, it does. Appreciate that, John. It's like it's interesting to say that when we look at the original Cures Act and open up data for patient consumption and patient sharing opportunities, and we'll talk a little bit more about additional FHIR implementation guides that might be coming out of the FHIR Argonaut group that have mentioned in HTI1. So, and then there is like, well, they don't want everything, or they don't have the right to share everything. There should be some protections there. So there's a to your point. I think if I'm an EHR developer, I'm a payer, and I've opened up my API, the expectations about what a patient may want to retrieve and or share have come into the conversation, which I think is important. And then again, the point about the insights condition. And here's again where a deeper dive into the fact that ONC and the industry in particular, obviously, are looking to continue measurement of adoption. And they said they just published a great article and a white paper on the fact that patient facing and the adoption of apps by patients is on the rise. And I think there's clarity around what we mean by apps, whether it is an app that might launch from a phone and still could be going through a web portal versus I don't necessarily have to log on to a web browser anymore. It's being replaced by app technology. And the underpinnings, I think, continue to move towards FHIR and APIs, which I think is important. But to the point about the additional reporting that ONC is really rightly so interested in, when we think about some of those conformance and adoption conditions as it relates to insights, they're looking to have a listing of apps that are connected to certified technology. So, what are the apps in terms of what the frequency is of adoption? So there's measurement there. And I think the cream will rise to the top there. The FHIR apps supported by the technologies, the volume of FHIR resources transferred in response to some of these API calls. So now we're starting to dig into the resources and the types, bulk data requests. So differentiating between, I might have a patient facing app or a provider that might search for a few patients. What other types of larger, whether for research or public health, that's going to look to make its way into measurement from the EHR side. And it's single patient and patient population electronic health information sharing through the API. So I think it's important, like I said, to recognize that in addition to what's in HTI 1 and for implementation guides and use case adoption, there is a reporting requirement that is now significantly centered around the use of APIs and which ones are being adopted, what their use cases are, and the volume of data. So it's quite interesting there. I thought it might be important now, John, to take a pivot and say, well, as we look at the Cures Act in general, as we look at what's coming in HTI-1, what about your experience and what you've seen throughout your career, and more recently, obviously, with the challenges around the API environment? I know I've certainly seen a few myself. We'll get to that, but I'd like to start with you for the benefit of those in attendance, if I could.
Yeah, there's a couple of things I think I really would key on. And the first is kind of a shared challenge for interoperability, both for FHIR, but also for the CDA standard as it's applied to use. And that's really dealing with the expansion of the US CDI over the course of time. Those of you who are familiar with the certification program and interoperability around use of certified HIT are aware that historically that's been really a clinical data set with some administrative demographics that are still supportive to the clinical encounter. It's kind of had this integrity of being a core data set that's very significant for transitions of care, for making available to coordinate care. But now we're beginning to see with version 3, and now that we know what version 4 is about, the introduction of more financial data, insurance information,
Right.
subscriber data, employer type, things of that nature. And so over the course of time, the credibility of the US CDI remaining that kind of integral whole as a whole interoperability requirement for FHIR based interoperability is kind of strained. It really puts out the question of should that be more um, profiled or right sized to the use case, kind of like what's going on with the use of the FHIR standard for electronic case reporting. I would say is a very good example of what the future of certification criteria based on the USCDI should be, that it's a library or a compendium, not that it's a monolith. The other thing that I think is really been confusing for a lot of stakeholders is how to apply the various requirements that operate between conditions of certification and information blocking when it comes to the FHIR standard and dealing with bulk data. And I'll highlight a couple of things. Um, First is I think people constantly forget that when they're thinking about can I charge for APIs? Can I charge for certified APIs? I think there's tremendous confusion that operates in the minds of many who aren't really close day to day to the certification program that the API condition of certification that does have some pretty stringent restrictions on how you can develop a fee structure for APIs, that only applies to certified APIs. It doesn't apply to non-certified APIs, which that's still a very extensive library of use cases that go well beyond certification. I think people
Right.
also get extremely confused about bulk data for EHI and the use of the bulk API standard as if they were synonyms, and they're not. And that's especially important when you're looking at requirements that involve transfers of large volumes of data, and what that gets into how it's asked for, what's the how would the content and manner exception work to apply when you're considering a response to request for bulk data. But unless that's what the requester is actually seeking, you're not restricted to solve the problem through the use of the bulk API standard. You certainly can, you don't have to. And that extends, the last thing I'll kind of touch on is with EHI export in particular. I've had in my consulting business a lot of questions from clients who have asked, well, what are my restrictions about it? What happened? When will it really come into play? And can I ever charge for its use? Or does this mean I can't charge for bulk data if somebody tries to challenge me that I'm an information blocker if I try to charge them for a bulk EHI data set? I think it's important to remember EHI export is not something you can charge for when it's used, when you're using the certified capability for the purpose that's described in the certification requirement, conversion of a system,
That's key.
when it comes to the bulk data. Now, I would advise people don't charge for its functionality if someone's using that very same capability to do something else. I've heard people bring up that I want to create an archive. I don't want to convert the data to a new system. I want to put it in an archive state to retain the ability to access it on occasion, like a cold file, if you will. I wouldn't get into mucking around trying to pick at the fringes and charging for straight up the bulk certified capability as it is in any way. But if people ask you to modify it, if they change the way the patients are selected, they change the data set that it actually produces, now you're getting into just normal straight up bulk EHI that you evaluate under the information blocking exceptions for content and manner and for licensing and fees as they may apply. So I think, John, those are the things I'm hearing a lot of questions about,
Right.
and
Yeah.
kind of let you continue it on some of the other things you've seen.
Yeah, sure. Yeah, appreciate that. And it's interesting to hear about, that when you think about the electronic health information and the provisioning of that. Sure, you do a little bit of that through the FHIR APIs, and whether that's through G10 bulk or some of the other categorized opportunities to provide data. And then there is really this looming for at least our EHR customers, the provision to ensure that the electronic health information provisioning is there. And it's a much larger data set. And there's been some confusion as well within that, some of it could be enabled by a FHIR API, but there is a whole hill of other data in various formats, whether it's an image, whether it's an archive, that might even span across multiple systems that a provider organization is going to field that request. So I think we're going to see some trickle down from that, and as we move more towards a FHIR API, and your app has even more patient data available to you, whether it's on your phone or tablet or likewise. I think that'll get distilled down a little bit. The other thing, too, is I'll harken back to the conditions and the fact that the EHRs themselves are likely to have some measurements, as we talked about, that, what type of apps are connecting, what percentage are doing bulk data, what percentage might be just doing patient-facing APIs. You see, there is an alignment there, obviously, with past and present requirements within the real-world testing realm. So the EHR community in particular is looking at, I have real world test plans that are getting wrapped up now for the following year. And I'm looking at this proposed rule where, it could drop at any time, and how that's going to shake out, that some of those measurements that you might see in conditions really run parallel to and may supplant what an EHR might be reporting, or at least support what they're reporting for real world testing measures, which we know are going to continue ad infinitum annually, obviously, for these EHRs. So we look at that. And then I think from a customer base, and we're fortunate here at Drummond to have a good customer base, as you referenced earlier in your introduction, is the challenges around the fact that there's the information blocking hovering, the provisioning, the securing of that, and then the additional guidance that is often needed, because it is a bit like, and I'll use an age-old term that we've all heard a little bit, it is a bit like the wild, wild west out there. There's really nothing preventing an app developer from approaching a physician practice or a hospital system group and providing this is a great product and this is how it would work really well and complementary to your information tech ecosystem. But what they do with the data. So I think there's some good work being done by the Karen Alliance. Their code of conduct is something that, from a Drummond perspective, we think that's important. We all are aware of, or maybe not, that the FTC obviously is involved and has a really nice overview in terms of how things might apply to the application ecosystem. But there's the challenges from the EHR side that we've written a little bit about. And the one side is, I do have a management burden to enable data sharing. And that management burden is somewhat complicated by information blocking and what I should make available. And frankly, the expensive resources that electronic or provider industry, or that they might actually be obviously on the payer side, or even some of these other ecosystems that are enabling access, the acumen of who's asking for the data, and then what they do with it. Yes, there's FTC, guidance around it. Yes, there's a Karen code of conduct around it, but who's really sort of policing that once an app gets access to data, how much of a good steward they are? So we're hoping to see that, with programs that are emerging, there'll be some good work there. And then just utilization. A lot of the EHRs that I talk to, look at this and say that there's some apps that are used that, patients certainly demand them. I think a fair amount of the portal technology that is web-based, although it continues that way, has made a nice movement to the app ecosystem and making it, when I think of an app, it is freely available on my phone. It might be, as referenced earlier, an app and that I access through the web, but I may not have the hardcore sign on through a web browser. So we look at that. And then the apps, talking to some of them, there's a repetitive process, at least today in time, that rightly so, whether it's a payer-rich API data source or a hospital system provider or research and development data source looking to populate a database, the idea that it's a repetitive step. Each one of those organizations has really set up their own unique gateway. Of course, you have to follow the standards and the implementation guides, but You, like me, 20 plus years in the interface business, you run up against implementation bias. And so I think there's still some challenges. It's in terms of info blocking, how much do I make available, and the support that I have to put fairly across those that are asking for it, and then backing up and saying that how to, as an app developer, I'm doing somewhat the same thing across multiple ecosystems. So it's pretty interesting to see how things are going to shape out. I think the proposed rule is going to help clarify that, and I think just like anything else, where private industry is really helped push the app ecosystem. There's been great opportunities for greenfields and development efforts to make really slick apps that fulfill niche and full-time needs between an EHR and a payer, for instance. That private industry is always really adept at. Things that are work well will become highly adopted as the work gets out there. So maybe while we have a few more minutes, John, you have a great take when we were talking a little bit earlier about setting up a session such as this, as we look at the industry going forward. Some of the uses from the financial administrative side, you had some really great insights that might be unique and interesting for the audience to hear, aside from the traditional, I think, clinical workflow and enhancement app ecosystem that's being supported out there. Would you mind taking a shot at that?
Yeah. So you mentioned it earlier, John, that there's the regulatory requirements around making payer held electronic health information available by APIs for patient access, provider access, sharing payer to payer when a beneficiary or subscriber were to change coverage, if they fall within ones that CMS has regulatory oversight of. The thing I really want to highlight, though, is that between some of those rules, especially around the electronic prior authorization requirements that are part of what CMS proposed last December. We're waiting for the final rule on that, along with a very closely timed rule for updating the HIPAA standard for what they are calling healthcare attachments. Um, there's a heavy overlap in that, and significantly around what they've called the PAR-D API. And if I get it right, it's prior authorization requirements, documentation and decision, I think is what PAR-D stands for. And that would be really, while they don't require them, they strongly recommend at CMS you looking to the Da Vinci implementation guides for profiling the FHIR standard for electronic prior authorization. Part of that is provision of medical documentation to support the prior authorization request. CMS also proposed an update to the HIPAA standards to do the same thing. And right now, they're literally constrained, and they outline it in the rulemaking that part of the function of the Party API would be to transform from X12 to FHIR and back. Or actually probably flow the other way. I got that a little bit backwards. But at any rate, to comply with HIPAA, you can't actually base the exchange end to end on the FHIR API standard. Um, but they also recognize that that's almost kind of a little silly because you're doing that for the face value of HIPAA compliance to transform data. So you also see conversations going on at the National Committee of Vital Health Statistics. Those of you who know, that's the actual federal advisory body that advises the secretary on all things HIPAA. So the recommendations around the future of the HIPAA EDI standards falls within their purview. In March of 22, they wrote a transmittal letter to the secretary that raised the recommendation of considering alternative basis of interoperability for HIPAA EDI, including based on the FHIR standard. So we're beginning to see regulatory conversations and advisory discussions around introducing the use of FHIR into financial transacting, especially around HIPAA EDI. And we have this rather glaring example of overlap between the electronic prior authorization proposals and the healthcare attachment proposals that came from CMS that raised the question of why are we doing transformation? Why don't we just transact in FHIR? So I think that's going to be something interesting to watch.
Agreed. Yeah, that's really a really good perspective, and I think again that's one of the things that aside from standard ONC legislation and proposed rules and all, really valuable insights for our audience members. So I do see a question popping up here that I'll actually entertain that. We've got about 3 or 4 minutes left in the session. So if anybody has any questions, feel free to chat them through the Q&A. We have Lynn in the background that'll manage those. But, one of the questions came through in terms of, what are we hearing in terms of adoption? Is where everything, a lot of the language appears to be, patient facing, but provider use cases and adoptions, where do you see that going? So I'll take a look at that one and say that from the perspective of looking at the FHIR app ecosystem, looking at the questions and the feedback from our largest customer base happens to be EHRs. We find that the adoption and the use cases for patient facing apps is it's relegated probably to some of the leaders and the ones you might expect. The one you might have on your phone, an uptick in access, albeit maybe perhaps through a portal. It is sitting there as an app on your phone. There is great interest in filling the gaps and really looking at provider use cases anywhere there's efficiencies. And I was talking to a provider at a large EHR gathering about a month ago, and his perspective was that disruptive technology is great, but the workflow of clinicians and providers has been disrupted to a large degree since meaningful use and going forward, increased documentation. Also, where there are opportunities for apps to assist and not create more work, and I don't have to log on to something else, right? That is a transparency and an efficiency that might be gained with a traditional workflow, perhaps within an EHR where they spend most of their time. Then they're looking at use cases like that from a provider perspective. And then again, you touched on it a little bit here, John. I'll hand you the microphone here after this. Is from a general and administrative perspective. We see a high uptick with, and I think the FHIR Argonaut Group is doing a really good job of this, is building consensus, approving implementation guides, and then we see EHRs in particular start to adopt workflow additions through FHIR apps that might enhance registration through kiosks. We look at the opportunities to serve up more data and streamline it through CDS hooks. So I think you look at, again, private industry coming together and running parallel with the rules and regulations and requirements to enhance and create efficiencies within provider and clinician and general and administrative workflows. So that's something that I've seen, just to answer that particular question. I don't know, John, if you have any other feedback. We got about a minute or so left. Some additional things that you're looking forward to, or things that you've heard with the FHIR app ecosystem from your perspective in your consulting business.
Yeah, I think that the thing really to pay attention to is the great intentionality I think that exists between the regulators, ONC, and partner federal agencies. They play a very strong role in driving interest for what kind of data will be formalized through the US CDI process, and that has a close coordination with HL7 on the development and maintenance of US core over time. So I think that maybe at one time it wasn't quite so tightly coupled, but I think it's become very tightly coupled. And there's a very significant intentionality to coordinate the timings of the developments of the supporting interoperability standards to go along with the US CDI. And nowhere is that more present than the API standards development that supports the US CDI. So, as that progresses over time, more and more data, is going to become available through the FHIR standard. And I think the expectation is just going to continue to drive that FHIR becomes the ubiquitous standard everywhere it can, if ONC and their partner agencies have anything to say about it.
Right. Yeah, I think that's probably a really great way of wrapping it up. I would encourage anybody that's on the webinar today or discovered this through LinkedIn. This session will be recorded and proliferated through that platform. drummondgroup.com. I put a couple of blogs out there as it relates to the FHIR app ecosystem. We're launching a program around FHIR apps, and would welcome any feedback along the way. So with that, we are right at time. John, again, it was a pleasure working with you through this process. And as everybody can tell, we had a nice coordinated discussion right down to our backgrounds and our wardrobe. So a pleasure, John. Thank you for joining Drummond Group. Appreciate all of attendees coming to the event, and I wish you a good rest of the week.
Thank you.